My name is Alistair Niemeijer. I work here as a university lecturer in care ethics, and I've just recently published this book, Surveilling Autonomy, Securing Care. And I try to explore what good care with surveillance technologies like GPS, video surveillance, but also the simpler sensor movement technologies, what good care could entail in the residential care for vulnerable people, i.e. people with dementia and intellectual disabilities. Just put this down. And the reason why we started this research was because these technologies are being increasingly used, not just to monitor people as a precaution for safety, but also to give them more freedom of movement as an alternative to classic forms of freedom, restraint and restriction. And so even though the fact that these technologies are used a lot, hardly any research has been done within a residential setting, and specifically for this population. So what I did was I first conducted a literature review to see what the ethical and practical aspects were of these technologies. And subsequently we did 2 concept mapping sessions. This sociological method developed by William Trochim, where you map out the concept, in this case, what does ideal care entail with these technologies, where we asked both professional carers and academics such as physicians, ethicists, what their view on ideal care with these technologies were. What we saw was there was quite a discrepancy or a difference between how the carers prioritized ideal care with surveillance technology and the academics. And carers emphasized safety, whereas the academics emphasized autonomy. Then I subsequently did ethnographic research in 2 institutions, a nursing home and with a dementia special care unit, and a facility for people with intellectual disabilities, where I focused on the experiences of the nursing staff and the support staff who had to apply these technologies, and the experiences of the clients who used these technologies or underwent these technologies. And in both groups, the experiences were quite ambivalent. And the nurses and support staff used certain technology very intensively, specifically the portaphone and the audio surveillance. Whereas on the other hand, other technologies they were very reluctant to use, such as the GPS and the tagging technology. Again, what you saw was that the reason why these nurses and support staff are reluctant is because they are very averse to taking a certain amount of risks. And the experience with the clients were ambivalent because it wasn't always beneficial to use these technologies. To give one example, there was a client who liked to walk with his support worker every day, and so the management have decided to give him GPS technology so he could walk on his own. And then what happened was he never came out the door again, even when it was sunny, and he liked being outside because he was raised on a farm. So eventually they had to reverse this measure, and so he could go out walking with his support worker again. So obviously he enjoyed the company more than the actual being able to walk autonomously. So in the discussion I reflect on my findings using several notions. One is the notion of practice of risk, just to open up this whole risk aversion and safety discourse that we seem to have when it comes to residential care for vulnerable people. and also I try to look beyond the standard moral guarantees of informed consent, which is currently the only moral guarantee to provide good care, and look towards other ethical theories such as that of Nussbaum and of Peter Paul Verbeek, a technology philosopher, to see if these can bring us more or better or sound moral care with these technologies. So, in a nutshell, this is what I've done. I could say a lot more about it, but I will defend my thesis within a week, 9 days time. So I welcome everyone who wants to come, and yeah, that's it.